right, can everybody hear me okay? All right, it's Friday. It's 1 o'clock. It's after lunch. We're all tired.
Good night.
I know, you're ready to go. I get that. But we have to talk a little bit more before we can do that. So I'm here to introduce the topic of clinical linkages, which, to be totally transparent, is not something that I normally talk about. I like to talk about diabetes and nutrition and the MOMS program, but I think we all learn a lot when we put these talks together, and I think as clinicians or as community members that work with clinicians, there's so much more that we can do to improve the care that we're providing and how we link back our clinical care to the communities that our patients live in. I think we've established this morning that we know that the data are bad surrounding diabetes, numbers and outcomes, and so we have to change the way that we're providing care. There has to be a paradigm shift for things to improve, and we all have to be willing to work together to achieve that end. So kind of like Dr. Laughley this morning, I've got some objectives for you guys. So we want to define the key components of effective clinical linkages, explore the value of clinical linkages, discuss challenges in developing those linkages, and then also review how we can strengthen those relationships. So what is a clinical linkage? It's the connection and collaboration between healthcare providers, organizations, and services to improve patient care. And because of this, we can enhance care coordination, continuity, and patient outcomes. What about the patient? So improving these linkages will ensure holistic, patient-centered care across multiple providers and settings. It hopefully prevents fragmented care and fragmented care settings. We enhance access to specialty care and resources. And then we also engage with the community programs that our patients could be serviced by. So some examples of linkages. So I'm obviously a big fan of team-based care models because that's what I do for a living. So we'll talk a little bit about those. Another big piece of this, though, is relationship building, and Dr. Laughley touched on that this morning, too. I'm also a big fan of the pop-up visit. We have to get to know each other. We have to visit each other, whether that's in the community setting or inviting people into your clinical setting, but that gives us the opportunity to learn from one another, but also get to know each other and really see the in and outs of what different people are doing. So that peer-to-peer relationship, it can also look like building peer-to-peer relationships with the people that you provide care with. It could be educator to educator, physician to physician, physician to educator, community health worker to physician, but really facilitating those relationships and freedom and comfort with consulting with one another to provide care to the same person. It could also be healthcare to public health, which we've talked a lot about before lunch. It could be healthcare to community organization or even healthcare to legislature. Tech integration is the part where it's like, ooh, I don't like that part, but really using our EHR to the best of its ability to be able to communicate with other providers in our system. It could also look like integration with patients' blood sugar monitoring data or blood pressure monitoring data, weight data, those kinds of things, so that we can really enhance the quality of maybe telehealth care that we're providing. And then that community and social services integration piece. So up here I've got a big thing, and you can see it better than maybe I thought you would be able to, but it's kind of this schematic for how over time we could increase collaboration among healthcare providers. We can't do all of these things up here at one time, but my goal is for you to pick something that maybe you're interested in implementing or utilizing within your own practice. A big piece of that is building multidisciplinary care teams. This for a lot of us would mean adding new or different types of team members that maybe we aren't used to working with. And for me initially, that does bring about a certain amount of discomfort, right? To get to know new people and provide care in tandem in a different way. But it could be diabetes educators, dietitians, social workers, psychologists, or pharmacists on that primary care or specialty team to work together to provide that care. That's really hard though, right? Has anybody ever listed a position for one of these things and tried to hire one? How long does it take to get one? I don't know, a year. Maybe never. Sometimes you close the position. So what about this idea of expanding the professional role of people that we already work with? If we have team members that we love and are impressed by, what if we empower them and help train them to become more, to gain additional certification? That could be a diabetes educator exam. It could be helping your medical assistant get their LPN. It could be a number of different things, but encouraging people to stay on your team and practice to a new level or to the full extent of their scope if they are already one of those things. And it can be simple things too, like there's all sorts of trainings out there, even just diabetes technology training or those kind of certificate programs that can help people learn more, but also feel like a more vested member of your team, like they're contributing a little bit more. You can operate in small teams or teamlets. So these could be led by providers. It does not have to be a physician. It could be any number of people on the team, but you kind of move together and introduce yourself as a group. People in our hospital just joke like the moms people are coming, like it's just a gaggle of people coming all together. But that relationship and multiple people within the same appointment can help increase patient comfort and trust. It could also be better coordinating care between primary care providers and specialists. So really getting that interdisciplinary communication. That's another good opportunity for that pop-up visit. Are we going to visit and talk to the people that refer to our clinics? Do we have relationships with those people? Do we round on those people's care together? Do we have a clear message and communication in the notes that we write so that they know what we're doing with their patient? Expanding access through non-traditional approaches. Telehealth isn't really non-traditional anymore, but in 2020, it sure felt non-traditional. And then other things, shared medical appointments. So providing that care within the same visit. It's efficient for the patient. They only have to travel to one appointment. They only have to get vitals done one time. They only have to get their labs done one time. And then group education as a means of an appointment too. So you could see your new patients together in a group, for instance. And then adding our community care partners to the clinical care team. This could be school nurses. We've heard about community health workers today, so I don't feel like I get to talk about them as much as I wanted to, but I think adding a community health care worker to your clinical team could be one of the most fabulous things that you could ever do. I was skeptical. I had no idea what to do with one when I got one, but we quickly learned that they are such a valuable translator of information from the clinician to the patient. And for the first time, you have this window into what your patient's life is like because they go and talk to them and see them where they live. And so you start to address some of that other 80%, right? Not the 20% clinical, but this other 80% of their life that we typically don't get to touch. High-functioning patient-centered teams, they're obviously more efficient. We see improved healthcare outcomes. We optimize health system performance. And then kind of an unexpected but beautiful piece of this is improving provider experience and reducing burden. You don't have to be alone working through this arduous, tiring schedule for the day. You can do this in tandem with other people that are working to take care of the same people. You also learn more because people do things different ways. And it's a really lovely thing to learn from the people that you work with. I do every day. So we've talked a lot about these clinical these interconnections within the clinical setting, but what about the clinical to the community piece? Again, this goes back to that idea of jumping out of our silo. So we have to inform the community of what we're doing. We can have a really cool program, a really great new idea, but if the people living in the community have no idea what we're doing, then we don't really have the opportunity to be a part of that community and get those community-based referrals, which are very meaningful. All right, and then the value to our patient, which is the most important piece. They hopefully have more streamlined care. I hope they feel heard when they have, hopefully more conscious, focused care. They don't have to repeat their story a million times. When you have diabetes, that's a really exhausting aspect of receiving care, especially if you have some other high-risk stuff going on. And then we do see improved outcomes. I haven't linked those studies here because I was being lazy, but we do see improvements in A1C, blood pressure, lipids, and weight. Value to the system, I guess we have to highlight these, but who cares? No, I'm just kidding. We see streamlined workflows and more efficient use of resources. We see reductions in hospital admissions and ER visits. And then, supposedly better health outcomes relate to saving some money. So that's a good thing, for people who care about that a lot. I'm going to point out the example that's near and dear to my heart. I thought, you thought you might get away with not hearing about it, but, I'm going to talk about it. So the moms team is our crack at providing this more coordinated level of care. We've got 3 sites. I'm at the Midlands one, but we've also got the upstate and low country as well. And so we aim to take those coordinated services and wrap them around the mom to improve the quality of her care. So these patients have access to a multidisciplinary care team within a single visit, and that service is coordinated throughout their pregnancy. We also hope to address that other 80% of their life through things like social determinants of health screenings that are acted on by our community health workers, mental health exams, retinal exams, continuous glucose monitoring for that tech integration piece, telehealth, insulin pump training and adjustment, and then access to fresh produce. We could not do it, though, without a lot of collaborating community partners. So partners like Food Share, Midlands Healthy Start with their wonderful team of community health workers, March of Dimes, who provides access to hygiene pantry supplies for our patients. And then bigger picture, Diabetes Initiative of South Carolina, who helps work on advocacy for the people with diabetes in our state. And we can kind of see how this big group of people, all these spokes of the healthcare team, can come together to take care of that mom, to have that healthy baby, and a healthy whole mama. Just a few challenges and then strengths. How am I on time? How many minutes do I? 5 minutes, okay. So challenges, communication is hard for everyone, right? I mean, I'm a bad communicator. I think, people are understanding what I'm saying, and then the opposite happens. So, that's always a challenge for all of us. We can have major differences in where we come from in the organizations that we work in. It's hard to work across organizations, and we can have a lack of standardized systems and protocols. Resource constraints. Team-based care works, we know this, but it's super expensive to have a team of all these specialty providers and care members. So it takes time to recoup that ongoing investment. Cost savings are seen in adverse outcomes that are prevented, which is a really difficult thing to put a number to, because how do we know how many bad things we prevented if they didn't happen? Ooh. And then other things that are difficult, turnover on highly skilled teams. You spend a lot of time investing and training these team members, but they can't always stay forever. So that's difficult financially, but also mentally for these small teams working together. What about resistance to change? Change is the worst. Who likes changing stuff? It's uncomfortable. It feels really good to stay the same. The unknown is scary. Losing money is scary. Burnout is very real when you're doing these things day in and day out. But the reality, again, our call to action, right? What we're doing isn't working, so we have to do better, and we have to get together to do that. Things that can help strengthen us. We talked about the yucky stuff, but what can we do to strengthen our work? We can standardize communication and case protocols. This has been big for us. We have some wonderful people on our team that are very skilled at this. Standardizing referral processes and care plans, treatment guidelines, so that every practice that you're serving knows what to expect. It's a clear message. The same thing happens each time. It could be with shared patient care checklists, shared smarter dot phrases, shared messaging. That messaging could be like a literal message, or just shared messaging, like, we say the same thing about what your blood sugar should be, or what's going to happen postpartum, or where you're going to go, what you're going to do. Regular case discussions can be very helpful to see how different people handle challenging situations. And then regular interdisciplinary care team meetings. Put stuff on the calendar, even if it's going to get canceled, keep it recurring so it doesn't fall off. Leveraging technology, we've talked a little bit about this, but we've got to share peer-to-peer, and then we've got to share patient-to-practice. It can feel really exhausting to get your patients set up to share in these different ways. It takes a lot of bandwidth and time, but once you're doing it, it's very fruitful and really increases time and access for your patient to your practice. Training and education, so accredited centers for training so we can learn from other people that are doing good quality work. That reminds me of the ECHO model, right? And then we need to support our peers in getting hours for certification. If we don't help other people grow and become more, then we're not going to have enough people to take care of all the people who need this level of care. So we've got to support people in doing that. And so we can see this continuum of a community linkage. So we go from this exchange of information like we're doing here today to coordinating that information, cooperating, collaborating, and then merging until we get to that point of operating as one entity where roles and cultures have blended. So linkage, right? My last slide. So we want to learn about community and clinical sectors, identify and engage key stakeholders, negotiate and agree on shared goals, know which operational structure to implement, aim to coordinate and manage the link, grow the linkage, and evaluate the linkage. All right. I don't think I have time for questions. All right. Thank you, guys.